My name is Kwak from Seoul National University Children's Hospital. Today's my talk is about anatomy and management of the truncus arteriosus. It's a basic and fundamental things. It makes me very nervous to talk about the basic things and the fundamental things in front of my teachers. So, truncus arteriosus is also called common aortic pulmonary trunk, common arterial trunk, or truncus arteriosus communis. The definition is one great artery arising from the base of the heart by way of the single semilunar truncal valve gives origin to the coronary, systemic, and one or two pulmonary arteries proximal to the origin of the brachiocephalic branches. This is the most famous classification for the truncus arteriosus. Type 1 is both pulmonary artery arising from the short pulmonary trunk here, and type 2, separate origin of the pulmonary artery from the posterior aspect of the truncus. And type 3 is separate origin of the pulmonary artery from the lateral aspect of the truncus. And type 4 is the agenesis of the pulmonary arterial trunk and absence of the pulmonary arteries. So now this is considered the pulmonary atresia with the MAPCA. Another classification done by Dr. Banfra, he called the truncus arteriosus communis. It seems Latin. The type A1 is the aortopulmonary septal remnant positive, like this. And type A2, no septal remnant here. And type A3 is one of the pulmonary artery not rising from the common arterial trunk. So in this case, the other one is supplies the blood from the ductus arteriosus to the lung. And type A4 is combined with the interrupted aortic arch. So if we have a letter B, that means the without VSD. So when we compare the two types of the classification, so the type 1, 2, they are corresponding with type A1 and A2. And as I mentioned about this, the pulmonary atresia with VSD MAPCA is called type 4 now. So because the solitary arterial trunk, not common arterial trunk by definition. So another classification was done by the Robert Anderson. So common arterial trunk, he called it. I think he did not like to use the Latin. So he divided this disease into the three categories: the aortic dominance and pulmonary dominance and balanced. The type, this type and this type and this type is belongs to the aortic dominance. Common arterial trunk continues to supply the brachiocephalic vessels. The pulmonary arteries arise from the common arterial trunk. Pulmonary dominance is combined with interrupted and hypoplastic aortic arch, or the coarctation of aorta is correspond with the fourth type of the Banfra. The confluent pulmonary segment is positive. The valence type is very rare. So he says all patients with a common arterial trunk have a common truncal valve. I think it is very important by definition, for the definition. So, and he does not apply the terms, the concordant or discordant for these patients, because the common arterial trunk is a form of a single ventricular outlet. So this is the type, the classical type 4 is, we called it the MAPCA, not anymore one of the type of the truncus arteriosus. So yesterday, the Professor Jiwon Ko described in detail about the embryological aspects for this disease. So I skipped these pictures. So the inferior truncus swelling and right truncus swelling come close together, and this part becomes the pulmonary valve, and this ventral and dorsal valvular swelling, I think makes them the conal septum here. So we sometimes use the hemi-truncus. It was used to describe a case of the common arterial trunk, giving rise to only one branch pulmonary artery. So anomalous origin of the right or left pulmonary artery from the aorta. But in this case, we have two separate arterial valves. This is misnomer. So because truncus arteriosus has only one common arterial valve. So we do not use this term anymore for this to describe this disease. Regarding the truncal valve, from the half to the 2/3 of the patients have 3 leaflets, and most of the 4 leaflets. And also fiber continuity exists just like in the normal aortic valve. And however, the 1/3 of the patients shows a severe myxomatous change in the truncal valve. About the VSD, the superior margin of the VSD is a truncal valve here, and inferior and anterior margin consists of the septal band of the 2 divisions of the septal band, the anterior limb and posterior extension. Dr. Shingo Kasara emphasized this structure yesterday in TOF. In the posterior margin, we have the muscular structure here between the VIF and the right posterior division of the septal band. So if this is separate the truncal valve and the tricuspid valve. So this makes the posterior margin of the VSD. But if we do not, if the patient does not have this part, the fibrotic continuity makes the posterior margin of the VSD. So when we repair in this kind of patients, we should be very careful not to injure the conduction system because the His bundle goes to this area. And this picture is the normal, the aortic valve and tricuspid relationship to understand the truncal valve VSD. So no conal septum in the alveoli. So management is medical treatment is not effective for preventing the congestive heart failure. So this is a surgical disease. So I think there are 2 important things about the surgery. One is extracardiac conduit, and the other one is a truncal valve. So for the extracardiac conduit, I think it is much depends on the surgeon's performance, but I think the conduit also makes a rule especially for the bleeding, and then we should minimize the right ventriculotomy. So many conduits are developed for the small babies. This is from the Japanese group, and this is currently used Contegra valve, internal jugular vein valve conduit, and this is traditionally used the valve conduit from I think this is Hancock, the valve conduit. And in Korea, the Professor Sung from Yangsan Busan National University makes the valve conduit homemade. So we also used this conduit in our operating room, and they continuously developed this conduit for better long-term outcomes. And now they make the commissural sutures here. So Professor Kim is over there, so you can ask him after this session. About the truncal valve repair, the Dr. Igor Konstantinov published the great the review paper in the Operate Techniques in Thoracic and Cardiovascular Surgery a couple of years ago. So he summarized many excellent surgical tips for these patients. So we can use the leaflet extension for the short cusp, and also we can reduce the annulus using the subcommissural annuloplasty sutures and ST junction plication like this. And also he introduced the suture valvuloplasty, the dysplastic valve he coaptated makes mimicking the three leaflets, and also the complete resection of the dysplastic leaflet and corresponding the sinus, and then reduce the ST junction and annulus. In cases the coronary artery involved the sinus resection, just like we do in the arterial switch operation. We harvested the button the coronary artery and then re-implanted the ideal place for the aortic root. In the intramural course, we can use the same, almost a similar technique to repair the truncal valve. So now I shortly introduce our center's long-term outcomes, 20 years experience, 51 patients, and we have 3 pulmonary artery bending as a first palliative surgery. And since 2003, we tried to minimize the priming volume and do the routine modified ultrafiltration. So we compared after the 2003. So the valve conduit type that was used like this, and this is survival curve, and this reoperation rate is about the conduit and the truncal valve. Truncal valve repair, the freedom from the truncal valve repair is the survival is good, but we cannot avoid the reoperation for these patients. So the reoperation predictors for any kind of reoperation, the age and conduit size affected, and the homograft was not so good. About the conduit size, overallly it was a risk factors, but since 2003, it is a little bit better outcomes for the small conduit size. And also the initial truncal valve regurgitation was predictors of the pulmonary valve related reoperation, and still we have a good result. So the current era in our center shows an acceptable result and improved perioperative nausea. It changed the risk factors for the outcomes. Reoperation not completely avoidable for the patients with a smaller conduit size and younger age at the operation, and initial tibial regurgitation was severe. This is end of my talk, and I will announce our next meeting about the Asian Association for the Pediatric and Congenital Heart Surgery. It will be held in this place next year. The president of this society is Dr. Sakamoto, and the meeting president will be Eun-Han Kim. So we will receive the abstract the end of the next April. So I hope everyone in this room will see next year in this place. Thank you.